remember first year MBBS physiology, this graph we would have seen before also. Okay, so what does this graph show? This graph is having three curves. One is the pressure, one is the flow, and one is the volume. So the pressure graph, it is if you can see during spontaneous breathing, what happens is there is a negative pressure which is being created. Okay, the pressure comes down, a negative pressure of somewhere around -8 to -10 is created, and then it again comes back to zero. So normal spontaneous breathing is a negative pressure breathing. Always keep that in mind. Okay, so this was the ventilator which was initially designed because जो हमारे lungs है physiologically they have a tendency of negative pressure breathing. So to support that negative pressure breathing, this was the ventilator which was designed initially. This is actually a negative pressure ventilator. Here there is a chamber, there is a metallic chamber जिसके अंदर में patient का chest जो है पूरा का पूरा जाएगा. And once the chest is inside, what this chamber, we have to close the chamber and it will create a negative pressure around the patient's chest. Okay, and because of that negative pressure, the thorax will be pulled, and once the thorax is pulled, there will be a negative pressure which helps the patient to breathe. So this was the ventilator from 1950s or 60s. Initially, what the ventilator used to look like. But unfortunately, it is not physiological, and we are not. I mean, if we use this type of ventilator, it has more complications. Secondly, we are not in a position to monitor the patient's breathing movement, chest, or the respiratory efforts, work of breathing. We cannot monitor. So because of that, these type of ventilators have gone now. Okay, but these are actually physiological. Okay, these are actually the negative pressure chambers which were the initial ventilators in 1950s or 60s. So now we have moved from there to something called a positive pressure ventilation. Okay, so जो ventilators हम आज use कर रहे हैं, those are all positive pressure ventilators. Positive pressure ventilator means what? If we assume that the child is having no spontaneous breathing effort of his own, ठीक है, अगर कोई बच्चा है, suppose severe birth asphyxia है, he is not having any spontaneous breathing efforts, so how does the ventilator help to breathe? It creates a positive pressure in the ventilator circuit. Okay. So यहाँ पे if you have the ventilator connected to the child, so here a positive pressure is created. Okay. And this positive pressure will create a pressure difference which allows the gas to flow from the ventilator to the patient's lungs. Okay. So that is why this is actually called a positive pressure ventilation. है ना? हम हर बार what we tell, positive pressure ventilation, PPV, 2 cycles of PPV, 3 cycles of PPV. During resuscitation, also we keep on telling. So what does that mean is because normal physiological breathing is negative pressure ventilation. What we are giving to the child by this way is a positive pressure ventilation. Okay, we are creating a pressure difference outside the thorax. Okay, so this is when the patient doesn't breathe on his own. Okay, so this is how the negative, the positive pressure. If you see the previous figure, here there is a negative pressure. Okay, the pressure is going down. Okay, whereas here if you see the pressure is going up. Okay, so this is actually a positive pressure ventilation which happens during assisted ventilation, right? Other things will be the same. The tidal volume and the flow will be the same. Only the pressure in spontaneous breathing, it is negative pressure, whereas in a ventilator breath, it is always a positive pressure breath. Okay. So, if you, so this is again a ventilator breath. Okay. So this is a ventilator breath, which is actually a positive pressure breath. What will happen now? Nowadays we are all targeting synchrony. Okay, I always keep on telling the residents that synchronize your ventilation with the patient's efforts. Okay, or we are now focusing more on high end flow sensors to allow more of synchronization. We want the ventilator to deliver a breath in synchrony with the patient's own efforts. Why do we want that? Because see, if I set if I keep the baby on a ventilator will deliver this positive pressure breath. Okay, this is what is expected from the ventilator. But what happens if this ventilator breath, it coincides with the baby's own breath, then there will be more pressure created. Okay, the pressure gradient which is created before, the pressure gradient was only this much. Okay, if I rely only on the ventilator breath, the pressure gradient will be only this much. Now, if the baby's breath and the ventilator breath, both of them they synchronize, the pressure gradient will be very huge. Now, once that pressure gradient is huge, the work of the baby will decrease. Okay, so the work of breathing for the baby will decrease. So that is why we should always target synchronization between the ventilator and the baby as far as possible. Okay, because it decreases the work of breathing, the transpulmonary pressure which is thus generated will be good enough for the gas flow, and as a result, the child will feel relaxed. The gas flow will be very easy to happen. Okay. So this was all about inspiration. Okay, so till now what I told is that inspiration is actually an active process. For that we need to create some pressure difference. Expiration by and large is always passive. Okay, so even when the child is on mechanical ventilator, in most of the cases the expiration is passive. In normal tidal breathing also the expiration is passive. If the child is on mechanical ventilator also the expiration is passive. Only one situation where the expiration is active is when the child is on high frequency ventilator. Other than that, in all the scenarios, in most or almost all the scenarios, the expiration phase is a passive phase. Okay, so expiration always happens passively under physiological conditions, and it is because of the elastic recoil of the lungs and the chest wall. Okay, so lungs and the chest wall, they have the elastin tissue. Okay, and that elastin tissue has a tendency to come back to its original shape. Okay, so if you can see here, it is just like a spring. So whenever the lung expands, there is a tendency to coil back to its normal. Whenever the chest wall expands, it has a tendency to come back to its normal. Okay, so because of this tendency, uh, the volume decreases. As the volume decreases, the pressure inside the lungs will increase. As the pressure inside the lung increases above the atmospheric pressure, the gas will go out from the lungs to the atmosphere. Okay, so this is how a normal expiration happens. Okay. Now, for inspiration, as I told, there should be a pressure difference between 2 points, between atmosphere and the baby's lung. Always there is a pressure difference. Now, how much pressure needs to be generated i- in either scenario? If the child is on ventilator, or if the child is breathing on his own, how much is actually the pressure the baby has to generate or the ventilator has to generate to ensure that, tidal volume, our main aim of putting a child on ventilator and delivering the positive pressure breath is that we want to deliver adequate tidal volume to the baby. Okay, so how much gas should flow from the ventilator to the baby, that is equivalent to your tidal volume. Okay, so we want that tidal volume should go from the ventilator to the baby, that is around 4 to 6 ml per kg in preterms, and in term babies we somewhere target it to be somewhere near should grow. Does because that pressure has to overcome two forces. One is the pressure due to the airway resistance. Okay. So whenever the gas has to flow from the ventilator to the baby's lungs, when I tell the baby's lungs, I actually mean the alveoli, because it is the alveoli which are the gas exchanging units. So the air has to travel from the, if the child is on non-invasive ventilation from the nose and the nasopharynx, if the child is on endotracheal tube, it has to travel through the endotracheal tube and then to the trachea, bronchi, all the generation of bronchioles, and then finally it will reach the alveoli. Okay, so for that, there will be some resistance offered by the airways. So it has to overcome that pressure. That pressure should be sufficient enough to overcome the pressure due to the airway resistance, and also it has to be sufficient enough to overcome the pressure due to the stiffness of the lungs. Okay, so as I told, all the tissues, that is the lung tissue and the chest wall, they have an inherent tendency to collapse. Okay, imagine a balloon. Okay, your lungs are nothing but a balloon. So अगर हम balloon को inflate करते हैं, it will come to a certain point. As soon as we leave the pressure, as soon as we keep it open to the air, what happens is balloon has a tendency to deflate. So similarly, it is with the lungs. Okay, so to keep to keep the lungs open, we have to overcome the stiffness pressure of the lungs. Okay, so for the gas to flow from point A to point B, or from the atmosphere to the baby, it has to overcome two pressures. That is the pressure due to the resistance of the airways, and second, it has to overcome the pressure due to the stiffness of the lungs. Okay, so this is how the equation of motion. I'll discuss this in more detail in the subsequent slides. Okay, but we have to keep this in mind that the pressure which I have to generate, it should be sufficient enough to overcome the resistance of the airways, and second, it has to overcome the pressure due to the stiffness of the lung tissues. Okay, then coming to a very important concept of elastance and compliance. Most of us know about it, but still I would like to touch upon it a little bit more in detail. So, elastance is actually nothing but the property of any substance to get back to its original shape whenever a distressing or a deforming stress is removed. Okay, so here in this case, it will be a pressure. So, as soon as you remove the pressure, the tendency of any object to go back to its original shape. Okay, so if you imagine a balloon. Okay, so as soon as I inflate the balloon, it will blow up in size. जैसे ही मैं inflation छोड़ के उसको open रखूंगा, it has a tendency to collapse. Okay, so that tendency of the balloon to come back to its original shape, to come back to its collapsed state, is known as the elastance. Okay, so as soon as I remove the pressure, it is called elastance. Now it again depends on two factors. When it comes to lungs, there are two factors responsible for it. One is the elastic fibers in the connective tissue of the lung, and second is the surface tension in the alveoli. Okay, so I'll touch upon the surface tension part a bit later. Next, coming to compliance. So compliance is actually nothing but the inverse of elastance. That is, it is actually a measure of the stiffness of the lung, and it refers to the stretchability of substance when it is subjected to deforming stress. Okay, so if I take the example of a balloon, if I want to measure its tendency to collapse after I remove the pressure, then I'm measuring the elastance. Whereas if I want to study how much the balloon will expand when I blow air at certain pressure, then I'm studying its compliance. ठीक है, तो अगर मुझे समझना है कि balloon कितना expand होगा with a certain pressure, then I'm studying its compliance. Whereas if I am studying कि भाई in how much is the tendency of that balloon to come back to its collapsed form, then I'm studying its elastance. So both of them are equally opposite. Okay, and compliance is actually a measure of the stiffness of the lung. It is defined as change in the volume per unit change in pressure. Okay, so we write it as delta V by delta P, that is change in the volume per unit change in pressure. Okay, so then there is something called the static compliance and a dynamic compliance. Okay, so static compliance is actually nothing but the compliance which we measure when there is no flow of air in the respiratory system. ठीक है, तो there is inspiration and then there is expiration. उसके बीच में if there is a pause, if there is a phase where there is no gas flow, I measure the compliance at that time point when there is no flow of gas. I measure how much volume has changed because of a certain pressure change, then it is called static compliance. But in real life scenario, ऐसा होता नहीं है. Respiration is a continuous process. There is inspiration followed by expiration. We hardly see a time whenever there is a pause of respiration. Okay. So what we measure more commonly in our ventilators, अगर हम हमारे ventilators में जाकर के देखेंगे तो एक compliance का value display होता है. So what that value is, it is actually a dynamic compliance, that is the compliance which is measured during the flow of air in the respiratory system, because continuously the ventilator is pushing some air. If the ventilator is not pushing air, the baby is exhaling out. So there is some flow of gas always there in the respiratory system. Okay, so there is hardly a phase in the respiratory system जहाँ पे कोई gas flow ना हो. Okay, so what the ventilator or our ventilators, what they measure at the bedside is more of the because it is calculated that the gas or the flow of air always has some resistance. Okay, so some part of the pressure which we have created, or pressure difference which we have created, will be needed to overcome the resistance of the gas flow. Okay, so that is why so some change in the pressure causes so the change in the pressure जो हमने किया है, some part of it is actually dissipated to overcome the pressure due to the resistance to gas flow. Okay, so there are some ideal scenario देखें, lab experiments देखें जहाँ पे कोई gas flow नहीं है, तो ideally with a change in pressure of say 10 centimeters of water, volume should change by around 10. But in real life scenario, because there is continuous flow of gas, तो जो volume change 10 होना चाहिए था, उसके बदले it will be 9 or 8.5 something like that. Okay, so that is why in real life scenario, the static compliance is always greater than the dynamic compliance. और the वेंटिलेटर में जो हम कंप्लायंस मेजर करते हैं, जो बेडसाइड वेंटिलेटर हमको मेजर करके देता है, दैट इज द डायनेमिक कंप्लायंस, दैट इज ऑलवेज लेस देन व्हाट इज द एक्चुअल लंग कंप्लायंस और द स्टैटिक लंग कंप्लायंस. ओके, can calculate C dyne, that is a dynamic compliance. We ourselves can calculate it, है ना. हम कई बार उसमें ढूंढते रहते हैं कि कितना है compliance, but we can easily calculate it bedside also. So suppose the tidal volume, expiratory tidal volume, I'm not talking about the inspiratory tidal volume. Expiratory tidal volume is around 14 ml. Okay, so that will be displayed constantly with each breath. How much is the tidal volume that is being exhaled is always displayed on the ventilator. ठीक है. So suppose if the expiratory tidal volume is 14 and the set PIP on the ventilator is 16 and the PWP is 5, 14 ml, and WLP, that is 16 minus 5, that comes to 11. Okay. So the dynamic compliance will be 1.27 ml per centimeter of water, or if we convert it to liters, I have put a less, 10 is less here, but it will come to 0.0012 liters per centimeter of water. Okay. Okay, so I'll show you the normal values of compliance later. So this actually indicates a low compliance because the pressure requirement is high. The expiratory tidal volume is a little bit on the lower side. Okay, so in that case, it indicates the compliance is a little bit less, right? So coming to the Laplace law, because I think few slides before in instance, I told that it depends on two factors. One is alveoli. For the purpose of understanding, we assume that the alveoli, they are spherical in shape. They are all rounded in shape. Okay, for our purpose of understanding, but actually they are polyhedral in shape. But for us to understand better, we are assuming that the alveoli, they are circular in shape. Okay, so if we assume that the alveoli are circular in shape, what happens is the alveoli on the inside, they are lined by uh, some liquid. Okay, so there is some liquid inside the lung tissue, and that liquid has a surface active protein called the surfactant. Okay, and above the surfactant there is air liquid interface. Okay, so if you have the alveoli, the inside of the alveoli is lined by a liquid. That liquid has some surfactant on its surface. Okay, and then you have the air. So there is an air liquid interface. Okay, so whenever there is an air liquid interface, as I told, alveoli, they are all like small balloons. Okay, so they have a tendency to collapse. Their natural tendency is to collapse. But what is preventing them from collapse is actually the surface active proteins which are present on the surface of the alveoli. So these surface active proteins are nothing but your surfactant. So the surfactant, they will help to decrease the surface tension. Okay, they will help to decrease the surface tension of the alveoli, and they will prevent the alveolar collapse. Okay, so how much is the pressure which is required to keep the alveoli open? That is given by the Laplace law. Okay. So what does this Laplace law tell? P is equal to St by R. So P is the pressure. So what pressure? Pressure required to keep a circular object open. ठीक है. तो अगर हम एक alveoli को गिनते हैं, so to keep that alveoli open, what I want is कि भाई alveoli should always be open, either in inspiration or in expiration. The alveoli should be open. If the alveoli collapse for some reason, there will be no gas exchange. ठीक है. Our target is to allow for a good gas exchange. For good gas exchange to happen, alveoli should remain open both during inspiration and expiration, so that gas exchange is a continuous process. Okay. So now to prevent the alveolar collapse, we need certain pressure to keep the alveoli open. Okay. कुछ हमको प्रेशर देना पड़ेगा ताकि वो alveoli क्लोज ना हो. ठीक है. तो how much pressure is needed? That depends on two factors. One is it is inversely proportional to the radius. ठीक है. तो the smaller the alveolus, more will be the pressure required to keep it open. ठीक है. जितना छोटा alveolus होगा, उसके opposite pressure हमको ज्यादा देना पड़ेगा to keep it open. And second is it is directly proportional to the surface tension. So the more surface tension, the lesser the surfactant, the more surface tension. The more the surface tension, more will be a tendency to collapse. So we need a more or a higher pressure to keep that alveolus open. Okay. So this is illustrated in this figure. If you see here, this red line which is in between, it is an indicator of the pressure. ठीक है. तो यहाँ पे outer rim पे you have a surfactant lining. If the surfactant is there, you require less pressure. ठीक है. But if for some reason यहाँ पे अगर surfactant नहीं है, without surfactant, okay, if you can read here, it is without surfactant. So if there is no surfactant here, the pressure which is required to keep this alveolus open will increase. You have a thin line here and a thick line here. So it indicates, okay, because there is no surfactant, surface tension will be high. Surface tension will be high, so the alveoli has a tendency to collapse, right? So this is one concept. Second, see, this alveolus has a larger diameter, okay, or a larger radius. Here the radius is large, so pressure required will be small. Here in this last picture, the radius is small. So since the radius is small, the pressure required to keep this alveolus open will be more. Okay, so this is what we call a Laplace law. These are some laws of physics, but they are very important when we discuss the respiratory mechanics. Okay, so that is why, I mean, why this concept is important for residents to understand, because that is why I always keep, scolding. I want PWP delivery to be more urgent rather than giving a surfactant on urgent basis, right? Because see, both are important. Okay, agar if you don't give PWP to the lungs, what happens is the alveoli will start to collapse. Okay. PWP is actually a continuous distending pressure. So when I give that PWP, what I am doing is by giving that pressure, I am preventing the alveoli to collapse. And once I am preventing the alveoli to collapse, their radius will be more. Okay, so once the radius is more, I require a little bit lesser pressure to keep them open. But if for some reason अगर मैंने initially PEEP नहीं दिया, जो outborn babies हम कई बार receive करते हैं ना, 2 hours 3 hours later हमारे पास में आते हैं. So by the time we receive those babies after 2 to 3 hours, what happens is कि उनके lungs में surfactant तो वैसे भी नहीं था. इन यूट्रो जब तक वो थे तब तक एल्वियोलाई वर ओपन बिकॉज द लंग्स वर फिल्ड विद फ्लूइड. जैसे ही बेबी स्टार्ट्स ब्रीदिंग ऑन हिज ओन, ऑल दैट लंग फ्लूइड गेट्स क्लियर्ड. वंस द लंग फ्लूइड इज क्लियर्ड, सर्फैक्टेंट नहीं है, द alveoli will start collapsing. By the time we receive the baby, after 2 to 3 hours, all the alveoli would be collapsed. Then, to recruit such a lung, to open up the alveoli again, we need a very high pressure. And until and unless you open up the alveoli, जो भी surfactant आप दे रहे हो, it is of no use. Because जो भी surfactant आप दोगे, वो कहाँ जाएगा? जो थोड़े बहुत open alveoli होंगे, वहां पे चला जाएगा, rather than going to the alveoli which are already collapsed, जहाँ पे surfactant deficiency ज्यादा है. Okay, so giving a surfactant is an emergency in RDS, but even bigger an emergency in RDS is to deliver adequate P, because until and unless you deliver adequate alveoli are open, there is no point in giving surfactant. Okay, so that is why the dictum is always recruit the lungs and then give surfactant. Okay, so now till now I was talking about the uh, lung compliance. Okay, so I was talking about the uh, distensibility or the stiffness of the lungs. Okay, but क्या है, suppose if as I am telling कि भाई lungs are just like a balloon. ठीक है, तो जैसे balloon की tendency होती है to collapse and come back to its original state, lungs usually have lungs पूरे collapse नहीं होते हैं. There is always some volume of air which is left behind in the lungs, जिसको हम क्या बोलते हैं, functional residual capacity. ठीक है, so lungs, they do not collapse completely. Even at the end of expiration, the lungs do not collapse completely. There is some amount of air left behind in the lungs. ठीक है, so why that happens is because जो लंग की टेंडेंसी है टू कोलैप्स, उसको बैलेंस करने के लिए एक ऑपोजिट फोर्स है. दैट ऑपोजिट फोर्स इज द चेस्ट वॉल कंप्लायंस. ठीक है, सो लंग्स दे हैव अ टेंडेंसी टू कोलैप्स, वेयर एज द चेस्ट इट हैज अ टेंडेंसी टू एक्सपैंड. ठीक है, ड्यूरिंग इंस्पिरेशन द चेस्ट goes in, during expiration it comes out. Okay, so it has a tendency to expand. So because of the opposing force of the chest wall, the lung compliance is to some extent balanced and the lung does not collapse completely. Okay, so as I have written here, the lung does not collapse completely during expiration due to the opposing force of the chest wall compliance. And as compared to the adult, the neonatal chest has got many differences. One thing is, in adults, the chest is our chest wall is ellipsoid in shape, whereas in newborns it is more of cylindrical in shape. Second is, in adults, the attachment of the ribs is oblique, whereas in newborns it is more horizontal. Third, the intercostal muscles, they have a longer course in adults, whereas they have a relatively shorter course in newborns. And also the attachment of the diaphragm in newborns is more horizontal, whereas in us it is attached at a higher point in the center. Okay, just behind the rib cage, the attachment of the diaphragm is sorry, just behind the manubrium sterni, the diaphragm attachment is high, and then it goes slanting below on either sides. Okay, but whereas in this thing newborns, it is more of a horizontal attachment. Okay, so because of all these developmental peculiarities in the newborn, the chest wall compliance is there to some extent, but it is not very high. Okay, जितना chest wall compliance हमारा अच्छा होगा उतना newborns का नहीं होगा, and that is primarily the reason why they have a very high compliant chest wall. High compliant chest wall means there will be more retractions when the stiffer lungs go in. ठीक है, so lungs they have a tendency to collapse. The chest wall has a tendency to go out, but जो tendency to go out of the chest wall is not as good as compared to the collapsing tendency of the lungs. As a result, there is less resistance to collapse. There is more tendency of the lungs to collapse, and there is more of atelectasis during a baby or in a preterm baby with RDS. Okay. So this figure shows the compliance of the newborn chest wall and the lungs. Okay. So if you can see, the chest wall compliance is very high, but the lung compliance is poor. Okay. So ये lung compliance है. This graph is actually less as compared to the chest wall compliance, which is very high. And as a result, the overall lung plus chest compliance is low. Okay. So this again shows the compliance that just to give you an idea. Okay, see if you are ventilating a child which has a poor lung compliance, so if you deliver a pressure of 1 centimeter, the volume change will be just 1 ml. Okay, but that same pressure can change can produce a larger volume change if I am having a lung which is having a good compliance. Okay, so these are the compliance values of the lung in various scenarios. Okay, so in a normal lung, it should be 0.005 liters per centimeter of water. In RDS, it will be 0.001. BPD also, the compliance of the lungs will be low. It is BPD is primarily a disease of the resistance, but MAS, we all know it is again primarily a disease of the lung resistance, but compliance will be a little bit low as compared to a normal lung. Okay. So I think it is less than a minute. I think I'll continue in the next talk, man.
Okay. Thank you, Dr. Sandeep. Please continue in second video.
Yes.